Welcome, everyone, to our live webcast, the latest in total joint replacement, including CJR, Medicare changes, and patient optimization for surgery. Thank you for joining us. My name is Mike. I'll be the operator for the presentation today. Now, before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings you may have. On the right-hand side of your screen, you see the text chat window. There's a large window which holds all of your sent messages and a smaller text box at the bottom where you can type in your questions. Send a question, click in the text box, and type your text. When you're finished, click the send button. All questions that you submit are only seen by today's presenter, and your questions will be responded to in the order in which they were received, will be addressed at the end of our presentation today. At the conclusion of the program, we will ask that you complete a brief post-event survey. If you would take a moment to complete this survey in order to receive credit for attending and providing feedback for our webinar for this evening. We do appreciate all of that feedback. We are joined today by our speaker, Dr. John Dundon. So at this time, I'd like to turn the microphone over to our speaker, Dr. Dundon, for opening remarks. Welcome to the program, sir.
Thank you. So thank you, everybody, for joining us. Got a bit of a broad topic today that we've been tasked with, talking about some of the CJR updates, CMS updates, and then something I've talked about numerous times, which was preoperative patient optimization. I got asked to give this talk on some of the updates at the end of the year, and then also just to kind of reiterate some of the things that we've done with patient optimization here at Morristown and some of the things that are going forward. Bear with us on this because the CMS updates, a lot of this just changed yesterday. Some of the stuff was preliminary, and a lot of it came to fruition, and there's still some things that are out there, and we'll touch on a lot of those things. If you have any questions, please let us know, and I'm happy to answer those as we go through. You don't have to just wait to the end. So if you have something that's pressing, just let us know, and we'll go ahead and address that. So at this point, we'll go ahead and get started. So no real important disclosures to talk for this talk, nothing important. So what are the objectives of this talk? First, we want to talk about CJR, a little background for those of you who aren't familiar on what CJR is. And then we also want to talk about some of the updates that are coming forward as Year 5 is coming, as we're starting to move past Year 5 and on and beyond, is what we're going to do with CJR, what's the future, and where are we going to. I want to talk about some of the updates that came forward with COVID-19 because of this. Some of the CMS changes for 2021, which as of 2 days ago were more tentative and now are a little bit more fixed as of yesterday. And then talk about something else that we wanted to talk about, which was preoperative patient optimization, something that we've talked about before. So CJR, it's the Comprehensive Care for Joint Replacement Program. So, we want to talk about a little bit of what is CJR, what are the current price targets that are out there, and how do we achieve some of those price targets, and what are some of the planned changes going forward as the program is, the initial part of the program is starting to wrap up, and where are we doing moving forward. So CJR, it's a Comprehensive Care for Joint Replacement model. This originally started about 5 years ago, and the idea was to try to find a way to create a value-based care system. The idea was to incentivize and reward value-based care rather than just reward procedural care. So the idea was to find a way to optimize the joint replacement pathway to make it more efficient, improve quality, and all while decreasing costs. So this was an idea it started with bundles and then moved to CJR to try to enhance hospital and surgeon cooperation in order to achieve a better product for a better cost. So the episode of care, the pathway begins with the episode of care, which is beginning to the admission to the hospital. It ends 90 days post-discharge with a look-back period. It includes all items that are related to the pathway of care. Yeah, it's originally targeted as a 5-year performance model, which we'll get into that a little bit later. And we wanted to set different target prices for different regions. It was originally implemented in 67 different geographic areas, and the idea was to have a retrospective model, and it excluded those with the prospective payments before, and to give people freedom to choose their providers still. So we're here now. So we're in years 4 and 5, which is 100% regional price target. We started off in years 1 and 2, comparing it to ourselves, then we moved to a more of a regional target-based price, which is where we're at now. So we're trying to provide care, high quality and highly efficient care compared to other people in the region. So this kind of gives you an outline, a diagram on exactly what's included in the target pricing. So it includes pre-admission testing and services and visits. It includes the perioperative, which is the hospital stay and fees, the surgeon fees, anesthesiology fees, and any consulting physicians, whether you have a medicine consult or if other cardiology consults or anything else are included in the hospital at that time. And then where we've really focused on a lot of our care is going, and where a lot of our efficiency is going to be in the post-operative period, which includes inpatient rehab facilities, skilled nursing facilities, any home health care, outpatient physical therapy, lab, DME, any other physician visits that are included, and then importantly, focus on readmissions and outpatient services. And those are things that can be targeted in order to minimize the downside risk and cost in that post-operative period. And then days 91 through 20 are a look-back period, just to make sure that people aren't trying to delay services until afterwards to keep that out of the bundle. So it works by having a claim triggered, and then after that happens, the patient goes through the process, whatever that, and makes sure they have the joint replacement surgery, whether they go to a nursing home, whether they go home with home health, whether they go straight to outpatient therapy. Everything is paid, and then it's retrospectively measured against the target price. And obviously, if it's lower, there's a check. If it's higher, then there is a penalty for that. And that's how this is retrospective bundling is going to work. So this kind of gives you an idea of where the target prices are. So this is an important slide to compare against where we're at, and this is why everything is so important. So these are the different DRGs for these patients. And here's where we started. So here's the start of this, and we're in the Middle Atlantic. So that's $41,000 was the original target price back in 2016. And you can see compared to regionally, we're now down to about a $36,000 target price. And this varies across regions. You know, some are a little bit lower. The mountain area is going to be down around $32,000. We're one of the higher ones in Middle Atlantic at $36,000. But you can see compared to where it is, we've definitely driven the price down significantly. Yeah, you can see we've gone down almost $5,000. So this is great savings that we've seen. The one downside to this is giving us a harder price to measure. I mean, if you and it's more difficult for us to manage that price when you see that. So we've already worked on quality, we've already driven down price, and now that we're on a regional plan, we're also working against that newer, harder target price in order to maintain. So, you know, moving forward, there's going to be some changes to the program, and one of the big ones that they have is there's been an extension of the CJR program in some of these mandatory locales, which includes Morristown Hospital. So we're getting an additional 3 years of the CJR program. This can be beneficial for us. We've done well in the CJR program, and we're one of the more successful programs in this. And this is something that can help us provide additional revenue for the hospital and for the joint replacement program as well. One of the things that's a downside to us is they're talking about a change in the target price from the previous 3 years to just the previous year and removing anchor weights. So the idea is that over the previous 3 years, the prices keep going down and down and down every year as we're getting more efficient at this. We're finding better ways to save money, provide higher level efficient quality care. And so each year the target price seems to go down. If they take out the previous 3 years, obviously that will certainly lower our target price if we're just comparing ourselves to the previous year. They're talking about one reconciliation instead of two, with just 6 months after the end of the program instead of a second one at 14 months, which is actually a benefit to us. So that way that there's only going to be one reconciliation. That's less costly. It's less work on our end. It's also less work on their end, which that can be a benefit. They're also considering right now bringing the outpatient THAs and total hips and total knees to be reconciled against the target price as well. A couple of years ago, they began to start with total knees and then total hips, bringing them off the inpatient-only list. And by doing that, it excluded some people from the CJR program. And now these are our healthier patients. These are people who are typically going to be lower cost in the system, and there's talk about bringing that back in and how to do that. There's also been talk about switching to a national pricing model instead of a regional pricing model. And obviously for us in this region, that would be a little bit counterproductive for us compared to some of the others, but we'll see how that goes. Other changes that are coming down for CJR. Currently, there's a discount for quality. The discount is taken off of the price. If you're an excellent quality program, it's only a 1.5% discount, acceptable of 3%, good 2%. Some of the proposed changes to this are taking the discount to 0% for excellent, which would be beneficial for us, especially since Morristown, we're a high level, we have excellent quality ratings. So this would decrease our discount, which is good. It'd be 1.5% for good and 3% for acceptable. So for those who are high performers, this would be beneficial to us. There's also talk in a plan of removing the restriction on physician gain sharing with this to consider getting rid of the 50% cap. Currently, there's a 50% cap on the gain sharing with the physicians compared to the fee. This could certainly be beneficial to the surgeons going forward. There's talk about getting rid of the fractures out of this and changing the DRGs to them instead of being 469 and 470 with and without fracture. The with fracture, they're talking about switching this to DRGs at 521 and 522. So this is a little bit up in the air on how they're going to do that right now. I haven't seen anything finalized on this. There's another thing, and this could hurt us a little bit, which is there's talk about changing the capitation. Currently, it's set at 2 standard deviations from the mean, which does cap some of our higher cost episodes of care, and which is going to be beneficial to us. It keeps the downside risk to us a little bit lower. There's a proposed change to set it at the 99th percentile, which would include more of these higher, more outlier joint replacement ventures that we have, where there are complications, infections, fractures, things like that. That could bring more of that in, but we'll have to see how that plays out. So some of the changes with COVID-19 that we're going to talk about with CJR, because this year was delayed with COVID-19 with a stop in elective surgery, there's a plan to extend the CJR year 3 months to give it another 3 months on this year, so that way it's not just a shortened year. There's been also, everybody's debating between CJR, BPCI, BPCIA on the downside risk and what to do with this during the pandemic. Currently, the plan is going to be for no downside risk to CJR during the pandemic, but none of this is completely finalized at this point. Some of the other programs are asking for some of these options as well, including BPCI and BPCIA programs, which are kind of off-spins, other bundled payment programs spun off from CJR. Well, not spun off, but separate, but very similar to CJR. Some of the options that have been floated for them would be postponement for the year to completely remove the year from, so that way there is no risk for them, or any COVID positive patients to remove them from the BPCI calculations, so that way they could still keep the year, take the upside and downside risk, but anybody who's COVID positive who may have a significantly higher cost because of this or associated with this, it would remove them from the bundle. So we'll have to see how that turns out. CMS, they've had some beneficial things for us for COVID-19 that have been included and have been helpful for physicians and hospitals alike. The biggest thing that we've seen is expanded telehealth coverage. They've expanded the codes. They've also decided, because one of the biggest things that they said was not everybody is going to have video capability, or even if they have video capability on their phone, not everybody can use it. We've all experienced this. All the physicians who have been telehealth at this point have been there with, the 85-year-old who can't FaceTime. They can't do those things, and you end up staring at a wall, and everybody gets frustrated. So they're including some of these audio codes as well for the expanded telehealth coverage, which has been beneficial to us. It helps us keep in contact with the patients, especially those who aren't healthy enough or are scared to go out, and has been very beneficial to everyone's health care. And they're going to expand. This is going to become a more permanent expansion at this point. They're expanding it into many of the other codes, including for psychiatry and some of these other places, in order to help deliver care to some of these people. There is an effort also to include out-of-state physicians and therapists, so that people can see people out of state without a medical license in that state. And the idea is to give more standardized care across the country and across the board, especially in more rural locations. So that way we can still provide care to people maybe outside of our normal realm of what we may consider our service area for these patients. And I think this could be a very beneficial thing long term, and I think this is something that now that it's here is going to become part of the future going forward. I don't think this is something that's going to go away anytime soon. Another thing that's here in order to help people, everybody at this point is experienced in any type of physician office, in the hospital, everywhere. They realize that delivering care is certainly more expensive at this time. Everything has to be sanitized differently. People have to wear masks. We have to wear protective eye gear. Everything is different and more expensive than it was before. You can't have the same amount of people in the waiting room. People have to wait in their cars, all these things. And then we have to keep our staff safe. We have to keep the staff provided with PPE. And so because of that, they've come up with CPT code 99072, which is a reimbursement of staff time and supplies during the pandemic. I know in our office we're pre-screening all these people as well, and I'm sure it's in other people's offices too. So this is extra time. So we have to have MAs, front desk staff, and other people calling these people, pre-screening these people prior to their appointment, making sure that they haven't traveled, making sure that they don't have fevers or any constitutional symptoms, anything else going on. And so this is a code that can be used during the public health emergency in order to get a reimbursement for this. And other insurers are starting to recognize this as well. It's not a lot, but it is something, and it's something that can be coded for the visits. It was technically only approved September 8th, and there is some question as to how we're going to use this and whether or not we're going to be using it retroactively. There is a big push to be able to use this retroactively for some of these people as well, and I think there's more to come on this. But I think it's something at this point that it's a code that we can use, something that is able to be used to get a couple extra dollars in order to help cover the cost of all the extra supplies and things that we've had to use during the pandemic. Although once the public health emergency is over, this will certainly be ended. There was one end date of 10/23, but that's been extended, so it's something that we're going to be able to use. Whether or not we're going to be able to retroactively use this for the patients we've already seen, that's more to come on that. So the next topic is CMS 2021 changes, and this is one that, because of this first thing, which is waiver of the 60-day delayed effect rule, this is just recently changed. As a matter of fact, yesterday they kind of just dropped some of the new changes, and I went over some of them as much as I could in the past 24 hours to update what I could. But they just yesterday released the changes that are planned for the 2021. And that's normally they have a 60-day delayed effect rule where they have to notify everyone and make the rule 60 days ahead. But because of the COVID-19 pandemic, they changed it to 30 days this year. So that's why it was a bit delayed. There were significant changes to the E&M coding this year, which will be beneficial to some, a little bit more harmful to others, and we can kind of go into some of that as well. RVUs were decreased, and that has to do with budget neutrality, and we'll talk about that. There was a relative decrease in payment to surgical fields. Separately, they also went after the total joint replacements as well, and that's currently being fought as well. And now there's a plan, and I have not seen the final rule on this yet, but there's a plan to remove all 266 of the musculoskeletal procedure codes from the inpatient-only list, which could be very difficult for us. So the one thing we were talking about was waiver of the 60-day rule. There's now only 30 days to rule for the rule, and that was because of COVID-19 this year. So they cut the time to review this and propose changes in half. So this was just actually made yesterday. So there are significant changes that have been proposed at this time and are going to be implemented. And it's definitely going to take time to implement. So this is a little bit harmful to some of us to try to implement some of these things. And I know many of the societies, the AAOS, the Radiology Society, the AANA, a lot of them are protesting some of these rules, and there'll be more of that to come. I think there's still going to be changes to some of this over the next 30 days as people discuss with, and there's also bills being passed, so we'll have to see how all of this goes. But this definitely, by decreasing the time in half, it does hamper our ability to respond to some of these changes. So E&M coding, this was a benefit to everybody from the E&M coding. They definitely simplified this, and they helped us on this. So I think this is beneficial. They eliminated the 99201 and 11s, which was beneficial. They weren't used very often for most people anyway. They eliminated the physical exam and history components from the billing and coding, which was nice, and it took away some of the documentation hassles that we've had with this. So I know we've all seen notes that are 20 pages long, full of things that were placed in the physical exam and the history because they had to, and they were computer generated. Now you just have to have medically appropriate physical exam and history to go along with your medical decision making, which does decrease some of the burden of paperwork and computer coding for us, and it can be helpful to us. It's strictly based now on medical decision making or time spent, which is good. And that's the whole idea of doing that, was to decrease the time spent on documentation and increase time spent with patient interaction, and to help us with that. They've also created a new code, GPC1X. Well, that was the temporary name for this code, and now it actually, as of yesterday, has a name, and I couldn't change it because I had to submit the slides 2 days before. So it's actually going to be G2211. And this is an additional third of an RVU that can be added mostly for primary care doctors, internal medicine doctors, for the treatment of chronic disease. So the long-term treatment of chronic disease can now be coded for, and you can get additional RVUs for it, and obviously additional money for that. They've also created a new code as well, G2212, along with that, and that code is for additional time spent with the patient above and beyond what was coded. So those are two additions that will certainly help people in the office. So here is going to be the new E&M codes. And as we can see, it's going to be medically appropriate history and or physical examination, and then medical decision making or time spent is going to drive this for the new patient. So this is much simpler. Instead of having to make sure you hit all of your bullet points for your history, make sure you hit all of your bullet points for the physical exam, and then make sure you hit the medical bullet points for medical decision making. Now it's just got to be appropriate history and physical exam. You don't have to go through all the points anymore. And now medical decision making is going to stay the same: straightforward, low, moderate, and high. And then total time spent is going to be listed as well, and it's straightforward, and so that way you have your coding. So this simplifies. This is much easier. It's much simpler for that. For the established patient care, again, same thing: straightforward, low, moderate, high. Obviously, because these are established patients, these are going to be lower times spent. But the great part here is this is a simplification of the code, and just appropriate history and physical exam. By having that, you can go move forward with medical decision making. And instead of having to document all of these other separate things, you just have to document either the time spent or the decision making spent. Now, the other beneficial part is there was a significant uptick for the E&M codes for the RVUs. So the RVUs have gone up significantly, as you can see, from 2020 to 21. So the relative the RVUs are definitely higher for these patients now. So this is part of what caused some turmoil with the global codes for surgery, and we'll talk about that shortly. But they definitely upped the RVUs for all of the E&M codes, which is certainly beneficial to anyone in the office. And the other great part, too, is that they give an extra third for, this is, again, G2211 code now on this GPC1X. Now that it's been defined, it actually has a code to it. And that can be used in the vast majority of primary care physicians' office visits. And it's expected to be used that way in order to up the RVUs. So the global fees, this is one of the things that's being protested by numerous societies. when they updated the E&M rates and the E&M RVUs, they did not include this into most of the surgical subspecialty fields. So part of the global fee for surgery includes the E&M for the post-op visits, the pre-op visits, and those things, and they did not include the update into there. So it was a relative decrease in these fees because of it. This is why it's being protested and fought by numerous societies. Most appropriately for me is AAOS, but the AANA has been very strong against this as well. And this update kind of devalued some of the surgical procedures and surgical fields by not updating the E&M portion of the global fee for the surgical. Certain fields were included in this, and that's where some of this is causing a little bit of a legal challenge by certain societies. Obstetrics, renal disease, and a few others did get bumps from this. And the legal challenge is technically illegal since there's not supposed to be a difference in coding between different physicians, different specialties between CMS. But this is kind of a technical snafu on whether or not this is how this plays out. That's more for lawyers to figure out. But they did benefit and update some of the fields while they left it out on some of the others. So that's why it's causing some people to raise some red flags, some of the societies, mostly the surgical societies, to raise some red flags on this. But we'll have to see how and what ends up coming of it. So some of the big winners and losers from the E&M updates are going to be endocrinology, rheumatology, PCPs, and obstetrics. You're looking probably about a 17% gain for some of those fields. Radiology and orthopedics, you're looking about somewhere between 11 and 20% drop on some of these things because of it. So we'll have to see how this all plays out. There's always new changes, and there's always fights as these things happen. So more may happen and more may change over the next month. One of the other big things that happened, so while they increased the RVUs for the outpatient E&M coding, they decreased the RVU rate by 11% from 3609 to 3226. So it kind of takes it down even further for some of those specialties that got hit by this, and that's why it's causing so much strife with certain people. A lot of people are arguing that this is the wrong time to do it with COVID-19, and some of these offices, especially some of the elective practices, hurting from that. But the problem is that there's a budget neutrality rate law with CMS, and they have to maintain budget neutrality. So when they added on the new codes and when they upped the RVUs for the E&M, it had to subsequently go down in the RVU rate. So more procedural-based subspecialties like radiology, especially orthopedics, obviously, and some of these others are going to see a hit from this, while others will still see a gain, just because they're getting more RVUs from it, even though the rate has gone down. Like we talked about, this is to compensate for the increase in the RVU changes from the E&M coding, and also they're expecting almost a 90% use out of the G, which is going to be G2211 now. So it's not, this is the temporary code. As of yesterday, it's officially changed to G2211 code, which is an additional third of an RVU. And like we talked about, budget neutrality is what's driving this RVU decrease in rate. AAOS and some of the others wanted to remove that code, but that doesn't seem to be, that's not going to happen. They've already said that they're going forward with that. There is a bill, House Resolution 8505, which has been proposed by some of the congressmen to remove the budget neutrality requirement in order to bring the RVU rate back up. So we'll have to see if that actually gets through, if anything happens with it. But as long as there's the budget neutrality, they're going to see the RVU decrease, and that's what it's got to be by law. If they were able to pass a new bill in order to get rid of the budget neutrality, then we can bring the RVU rate up some, which will help offload some of this for other people. So there's a lot of changes. As always, a lot of changes this year. Total joint replacement. So this is another one that they're actually talking about decreasing the RVUs on. So not only keeping it the same instead of going up like some of the others, but they're actually talking about decreasing the work relative value units for that down to 19.6, which is it's another 5% decrease in the work relative value unit on top of the 11% reduction in payment. So this is a pretty significant jump for us. And then obviously AAOS and AAHKS are going to be protesting this, but we'll have to see what happens. The one thing that they've seen is that patients are going home sooner, and they're spending less time in the operative room, and we're able to do these things for cheaper because of that and a more efficient care. And they're seeing that as it being lower value. But this does not account for all the increased time spent in preoperative optimization, joint classes, and everything else. And so that's one of the things that's being talked about. It's the letter from the AAOS and AAHKS is basically saying this is being viewed as punishment for reducing costs, because we were able to drive the cost, the average episode of care cost from almost $15,000 in some of these patients over the past 7 years. It's being viewed as a lower RVU, whereas we're showing that we're giving more efficient care. So that's where the fight is coming in on that. This is actually kind of a summary slide here, and this is actually presented by the AAHKS and AAOS. So, obviously it's going to be skewed in our favor. But, the 25th percentile, for RVUs as calculated is 22.5 and 22.14 for a total joint replacement. It's currently getting billed out at 20.72, and the median is 24. So it's already below what's average, and then they're proposing that it gets dropped even further. So one of the things that they're talking about doing is potentially adding on RVU for preoperative H&Ps and preoperative optimization to try to get some of the RVUs back, but do it through the preoperative screening process. And we'll have to see how that goes and what happens with that moving forward. But that is certainly one of the things, since they're dropping the RVUs, they're trying to say that there is a potential that we should be getting RVUs for the preoperative screening and optimization, which will have to be documented. So we'll have to see what ends up happening with that. The inpatient-only list is another change. There's a recommended removal of all 266 codes from the inpatient-only list. For those of us in total hip and total knee, we've known that this has caused a bit of an administrative nightmare for some of these patients, and it's led to denials of patients who are having surgery because of this. You have to do certain criteria to maintain people as inpatient, as outpatient, and sometimes it gets confusing as to which one is which. So removing all of the codes from the inpatient-only list, I think, will only further muddy the waters and lead to further administrative problems. This is even including lower extremity amputations and femur fractures. There's a talk of trying to remove all of this. So there's obviously a big fight about this to try to prevent this from happening, because a lot of these that they're trying to remove are just not medically appropriate for that. This will certainly result in denied admissions if they have to do it, because we have to prove that people meet admission criteria. And it can potentially lead to procedures just being paid as if in the outpatient setting. And there's obviously no data in a lot of these cases to support the doing this. So right now this is currently being fought by the Academy and by the American Association of Hip and Knee Surgeons, which is AAOS. So those are going through some of the big Medicare and CJR updates. And so now at this point, I think we'll kind of switch to, we got asked to talk about preoperative risk optimization as well. But this is something I've talked about a lot. This is something I've been a big supporter of and have always been involved in, since fellowship and on and beyond, into a private practice here at Morristown. So preoperative risk optimization, I think, and the important part with this is to realize that risk optimization does not mean picking winners and losers in this. You don't just stop doing surgery on people because they're sick. Sick people still need hip and knee replacements, still need medical procedures as well. What we have to do is find out, is there a way that we can minimize the risk? If you get to a point where you can't further modify any risk factors, surgery is reasonable at that time, and you just accept that those are non-modifiable factors. But modifiable factors are some of the most important things we can do to improve our outcomes and decrease our complication rates. So the number one modifiable risk factor, and now the insurance companies are coming on this, which is certainly helpful. I know a lot of patients don't like it, but it makes life easier when the insurance companies have come on this, which is BMI. Many, like Blue Cross Blue Shield, many of the other insurers have required weight loss. and BMI cutoffs of 40s, which is what I use as well. And by using these cutoffs and having insurance companies, backing you up on these things, it takes some of the onus off on you, which is helpful. I know when I first started doing this, a lot of patients would just get mad when you tell them you have to lose weight in order for your joint replacement. We still say that, and even the insurance companies that don't require the weight loss, I still move forward with that, and I still make them lose weight prior to surgery. But having certain insurance companies mandated certainly takes some of the onus off you and takes some of the pressure off when you have to help these people do it. So the super obese patients, the BMI is over 45, they have an 8.44 times higher risk of developing complications than the average weight patient. So this is an absolute modifiable risk factor. Some of these complications are huge. Acute renal failure, respiratory failure, that's a big one. Most of these patients are going to have sleep apnea, which puts them at increased risk as well. Infections, venous thromboembolic events, anemia, requirement of transfer to the ICU, urinary tract infections, and one of the big things is wound drainage. As we know, infections are just absolute killers in these procedures, especially in total hip and total knee. So when we close these patients and they have a large fat layer over top, you end up with some fat necrosis, and almost all these people have at least a little bit of drainage when you have that postoperatively. But anytime you have wound drainage, you have to worry about infection. The other one, and this is an absolute no-go for any of my patients, even though it's not everybody mandates it, is smoking. This is completely modifiable. There's a 24% higher risk of postoperative complications compared to non-smokers. Smokers are more likely to have infections, pneumonia, stroke, and mortality after total joint replacement. And these are significant numbers. So this is an absolute no-go. Any of my patients, or all my patients, are required to stop smoking prior to surgery. Anybody who I am concerned is lying to me, I actually nicotine test them. And I tell them I'm nicotine testing them, and we will cancel them if that happens. Diabetes, uncontrolled diabetes certainly has a higher risk of complications compared with both controlled diabetic and non-diabetic patients. Perioperative hyperglycemia is a problem. It's important to keep blood sugars below 200 in the postoperative period. And elevated blood sugars above 200 are a significant risk factor for infection. Absolutely a significant risk factor for infection. So it's important to have tight glycemic control in the postoperative period. And I use a hemoglobin A1C as a cutoff. Everybody's got a number somewhere between 7 and 8 that they prefer to use. But tight glycemic control is imperative in order to keep infection risk low. One of the things we've certainly used in order to move forward with this, something we've implemented here and we've worked hard on here. I know Eileen and Mina have both helped out tremendously with this as well, which is the readmission risk assessment tool. I've talked about this before. It's something we've done here. This was started when I was in fellowship. None of these people are actually there anymore. Oh, Joe Bosco's still there, but the rest of them are gone. But this is something we've worked on previously, and we're now implemented here, and I still use this in my practice. And what this does is it looks at different risk factors and it gives the people a preoperative risk score to look at their readmission rate and their risk for complications. And there are and we've created a tool in order to minimize the risk and give them options in order to lower the risk for them. It talks about anywhere from previous MRSA infections, smoking, obesity, diabetes control, physical deconditioning, previous VTEs, and cardiovascular disease. And what we found is that, uncontrolled diabetes, history of VTE, and obesity are some of our big risk factors in the previous studies. And the more of these combined things you have, the higher your risk of readmission, the higher your risk of complication. So, one problem, they compound in an exponential fashion. They don't just compound in a linear fashion, they compound in an exponential fashion. So the more of these things that you control, you actually can decrease their risks exponentially. So some of the data that we've seen here with these patients, and we've actually got more data now, and we're working at publishing it, is that patients with a score over 4 are going to have significantly higher risk of readmission. So we found that in almost all of our studies that we've done. So it's over double the readmission if you have a risk over 4 than if you have a risk of less than 4. And so that's important when you're optimizing these patients. It's important to keep smoking cessation. It's important to have good glycemic control on these patients. And here's what we see. Oh, my circle moved. Once you get up to a certain number, once you get up to around a 6, your odds ratio of readmission in 30 days goes up to 17 times. So this is a significant number, between 4 to 6 to greater than 6. So greater than 6 compared to less than 4, you have a 17 times higher risk of readmission. So these are the people that you have to target. That group from 4 to 6 and above 6 have to be targeted, and everything has to be done in order to optimize these people. And so we've created different pathways. So for obesity, we've got nutritional counseling, we've got weight loss surgeons, and we have everything else that we have. Whenever I have these patients, I give them a list. I give them names, I give them numbers, and then we follow them up. I follow them up every 6 to 8 weeks for weight checks for patients who are willing to go through the process. And so that way, you just bring them into the office, we do a weight check, we do a quick talk just to see where they're at and how they're progressing. That way they know they haven't been lost in the fold, they haven't just been turned away. Same thing with diabetes. We get them in with a primary care doctor. If they need to see an endocrinologist, we help them. We give them names, we give them numbers, and then we follow them up. We find out how the next one is. Smoking cessation, same thing. We get them set up with their primary care doctors, keep them moving, and then if need be, and if they tell us that they've quit, we'll check them. We do smoking cessation programs, and then we check their nicotine levels to make sure that they've gone forward with it. One of the questions that we have is alcohol abuse part of the RRAT? Yes, absolutely. People who are actively using drugs or alcohol are considered a no-go for these patients for surgery. So active drug or active alcohol use is a no-go. Now, unfortunately, people will lie about alcohol and they'll minimize, so sometimes that's difficult to find out and weed out completely. But most people are pretty honest, and most people will be truthful about it. But alcohol abuse is certainly one of the parts. And again, here's some more data showing the 30-day readmission rate here. Almost a third of the people who have an RRAT of greater than 6 or have these higher risk factors are going to end up getting readmitted. So 33%. When you compare that to our more well-maintained people at 2.8%, the people who are at risk still double at 4.6, but the people who have numerous risk factors are going to have a significantly higher risk of readmission. So for us, we found our number one thing was obesity. Obesity. Previous history of VTE, also high, which correlates with the previous studies that we've seen, and uncontrolled diabetes. So the biggest modifiable risk factor we've seen, and one of the things I think that keep the closest eye on is going to be obesity. This is certainly our number one risk factor that we have that we can modify. I think we got to get rid of the taboo with a lot of this. People don't want to talk about weight a lot of times. I'm very, very upfront about it, but you got to be careful. I mean, there's a way to be tactful and upfront about it and talk to people about their weight and discuss what can be done and discuss some of the reasons why we're trying to improve these things. And what I've found is that most people are quite receptive as long as you approach them in a manner in which you're giving them options and you're giving them solutions and you're discussing why those solutions are important. That it's very rare that people just get mad and leave. Most of the people that I talk to are relieved that you'll talk about it and are happy to take some of the suggestions. Even if they don't follow through, they're at least happy to discuss it. VTE risk or history of VTE risk, I risk stratify my protocols on blood thinners postoperatively with these people to hopefully minimize the risk. The data is a little mixed on that. Some of the Rothman data is showing that this doesn't matter whether you risk stratify them, that they're at high risk no matter what, or they're at low risk no matter what, and they like to stick with a strict aspirin protocol, which I only use for low risk. There are other people and other studies saying that it can provide effect, but that's definitely mixed. Diabetes control, there's no question about. There's great studies on these that tight glycemic control is going to lower your complication rate and lower your infection rate. And it's very important to have an open line of communication with the primary care docs because they really are the people that can help you maximize these patients and make sure that they're on the same page with you. Because when they're on board with you and they're helping you to get these patients optimized, it's a lot more successful than you trying to do it on your own. I'm not going to be able to manage diabetes near as well as a primary care doctor or an endocrinologist, and there's no question about that. So their help is instrumental in this. One of the things I was talking about before is the moral hazard of optimization. Does this mean we're just leaving people out on their own and just ignoring patients and potentially sending them to other surgeons who are going to take on the risk and, potentially get them into places? Morristown is a place where we do optimization, and we have great rates and great success and great surgeons here. So the question is, will they just go down the street and just find somebody else to do it? That's something that we have to be concerned about. But the idea is not to exclude people from surgery. The idea is to maximize how safe they can be. I think this is the biggest thing. That the idea between non-maleficence and beneficence, we're not trying to stop people from getting surgery. We're trying to maximize their chance at a good outcome. And you have to bring it to people that way. There's some people that say it doesn't matter. People should be able to do whatever they want. It's their body. Well, I would disagree, because you're potentially doing them harm. And that's the whole idea between that. I am on the side that if you're not willing to optimize your modifiable risk factors, then you don't have that right to surgery, and that it's not something that is owed to you, but something we have to work for and strive for. So that way we all end up at the same good, positive outcome together. There is the idea of cost to the system as a whole. That's something that is argued on that, and it's something that this article here brings up. I think that's a less strong argument when you look at the system as a whole. I think you have to look at it as the individual patient and doing the best for them, and that's the way I view it. But it's certainly a debate throughout. There are definitely people who will, when they talk about optimization, say that we are just, they call it lemon dropping, or just dropping bad patients, dropping sick patients to get better numbers. And I disagree. I mean, I still operate on sick patients. I don't have a problem operating on sick patients. I just ask that we do everything that we can to minimize all their risk factors. And with that being said, are there any questions regard to any of this?
All right, very well. And just a reminder to ask a question, if you're connected via the telephone, press *# on your telephone keypad now. And also a reminder, text chat located on the right-hand side of your screen to submit a question. Simply type your question in the small text box at the bottom. When you're finished, click on the send button. And again, we'll go ahead and give our audience members a few moments here, Dr. Dundon, and see if they have any additional questions for you. Well, Dr. Dundon, it would appear that there are no additional questions at this time, at least. So any concluding thoughts you'd like to pass along before we wrap up our program?
There's one question.
We do have another question. Yes, sir.
There's one question here. So do you suggest pre-procedure PT? Yes, I am a big fan of pre-procedure PT. I give all my patients home exercise programs to work on prior to surgery. I think it's extremely helpful. The stronger that the quad is, the better that people's balance is preoperatively, the better and the faster their outcome is postoperatively. I certainly agree with that. Pre-procedure PT, though, can get a little tricky as some patients only have limited numbers of physical therapy. So a lot of times when I send them to pre-op PT, if it's going to be for pre-op PT, I'll send them for a couple sessions and then have them work on a home exercise program past that. So that way they can maximize the amount of sessions that they have postoperatively, because we definitely have a problem with some people running out of their physical therapy in the postoperative period.
All right, very well. Any additional concluding thoughts you'd like to pass along before we wrap up the program today?
No, I'd just like to thank everybody for your time. If you have any questions, please feel free to contact me anytime.
All right, sounds great. Thanks again for a tremendous presentation this evening. On behalf of Atlantic Health System Morristown, Hackettstown, and Newton Medical Center's Orthopedic Surgery, we would like to thank you all for your participation in today's event. Post-event survey will appear requesting your feedback. If you would take a moment to complete this survey in order to receive credit for attending the webinar. This concludes today's program. Thanks, everyone. Have a great rest of your day.